Cool. So welcome to our session on the circle of life. So we're going to start with Adrian, Adrian, do you want to introduce yourself?
Yes, hi, I'm Adrian. I'm a foundation doctor in the Wessex Deanery in Basingstoke, and I'm a graduate from St George's, and that's it about me for now.
So Adrian's going to be going through puberty and like developmental disorders, and then we've got Tim. Do you want to say hi?
Hi, I'm Tim. I also did the GEP course at St George's.
And Tim's going to be teaching menopause today, and then we've got Alyssa.
So I'm Alyssa. I'm a GP trainee in West London, and I also graduated from George's as well.
And then we've got Ash.
Yeah, so I'm an F1 in North West London, and also graduated from the GEP course at George's.
And then I'm Anea. I'm one of the F1s, GEP at George's, and now also at George's as well for my F1. Cool. So we'll get started just talking a bit. We have polls today. So in our past few comments, we've had some feedback that we want polls. So Ash is going to talk you through how they work.
Cool. So we found this thing called VBox, which is really good. And what you need to do is just, if you scan the QR code, or I will also post in the chat the link for the polls as well. One or the other, if you do that, and then you should have access to the polls, which you've already started. And then as we're going through each of the SBAs, we'll just open up each poll, give you about 20 to 30 seconds to put in your answers, and then everyone's going to go over the answers, and then we'll just carry on like that. For anyone who might be joining later, I guess I'll just post the link a bit later on as well to get more people involved.
Cool. Should we hand over to Adrian now? Do you want to get started?
Cool. Yeah, let's do it. Thanks, guys. Okay, welcome everyone. And today's series, we're going to start off with sexual development and puberty. Now, I must give credit to Emily, who created the slides, and Ash as well, with all the animations and stuff. And I'll be presenting the information within it. By all means, if you do have any questions, you can ask me or interrupt at any time, but if you want to just put them in the chat, that's also great, or just leave all your questions to the end. Great. So just a few learning objectives. So we're just going to go over the structure of involved in male fertility. We'll look at the descent of the testes, the inguinal canal, sex determination, process of sexual differentiation. We'll look at ambiguous genitalia, puberty, some endocrine control of female gamete production, and menstrual cycle. But these are all just briefly. It's basically obviously a crash course. It's more sort of like a revision series. Okay, so if you've got the VBox all set up, then we're going to go with the first question, and that is, where is sperm stored? This is just a thing of fact, really. Do let me know when the poll is closed. I'm going to try and follow on my phone.
Yeah, if we just give about 20 to 30 seconds.
Okay, cool. Yeah.
If everyone's answered, then we can also do that too. So I think everyone's answered.
Yeah.
I'll close the poll now.
Okay, cool. So, great. So we've got what? The majority of you said B, and that's correct. This is just a one of fact, yeah. So sperm is created in the epididymis. Okay. Oh, sorry, I'm not created. Stored in the epididymis. This is where mature sperm is stored. Okay. The second question is, where is most of the seminal fluid made? The keyword most. Most people answered is yeah.
Yeah, I think so. Yeah. And close the poll.
Yeah. Cool. Okay. Some people mentioned D, and some people mentioned E. Majority mentioned D. The key word is most. Okay, so most of it, roughly around 70%, is produced in the seminal vesicles. Okay, it's called seminal fluid, and about 20% in the prostate. So both right, but one more correct than the other. Yeah. Okay, so let's just quickly go over the male anatomy. So we've obviously got the testes, where the gonads are, male gonads, and they produce the spermatozoa, keyword. And as they mature, they basically get stored in the epididymis, okay, which is where one of the first questions we asked sort of came from, how that relied in. Now, once they're matured and the whole start of ejaculation, they're then transferred or transported via the vas deferens, okay, from the epididymis to the ejaculatory duct, okay, which is in the seminal vesicle just there, and then basically it goes via the prostate where seminal fluid is made and ejaculation occurs. Okay, so we've got the testes, we've got the epididymis, we've got the vas deferens, we've got seminal vesicle, which secretes this alkali seminal fluid, and then we've got the prostate gland, which surrounds the urethra. Okay, great. So the third question is, what is the name of the fibrous cord that connects the fetal testes with the bottom of the scrotum?
Just give it a couple more seconds.
Yeah.
Okay, I'm going to close the poll now.
Yeah. Great. So 100% for D, gubernaculum. This is quite an important bit just to remember. It's just a key thing to remember. Okay, so the gubernaculum fails to sort of stretch or to elongate. Okay, and so as the inguinal sort of canal, which we'll go into in the next slide, starts to develop, this gubernaculum, which is attached to the scrotal wall, if you want to say that, moves with it and pulls the testes down. Okay, so that is the fibrous cord which connects the fetal testes with the bottom of the scrotum. And in this image, you can see it here. You can see sort of the sort of tail of the epididymis here, and as you travel along, you'll have the head of the epididymis further up here. Okay, so it's a nice key question. Most people got that right. Okay, great. So now let's look at the testicular descent in a little bit more detail. And there are some sort of nice key things that you can use to remember the descent of the testes. One thing I always remember was tie ice, and I think most people would have heard about this through some reading, some kind of mnemonic. Now, the testes sort of develop on the posterior part of the actual, in the posterior part of the abdomen, which we call the retroperitoneal part. And through development of the pelvic cavity is guided by the gubernaculum, that structure we just discussed earlier on. The inguinal canal, which is quite important, quite key as it develops, is where the testes and the gubernaculum pulls the testes through, and is eventually where we get the development of the cord. Okay, spermatic cord, and the development of the scrotum itself. Now, there are three key layers that you need to know of the inguinal canal. Okay, we've got the transversalis fascia, we've got the internal oblique and the external oblique, and as they create this processus vaginalis, which eventually becomes the actual scrotum sac, if you want to call it, it then turns into, or the name changes into, the internal spermatic fascia, okay, the cremasteric fascia, or the muscle, and the external spermatic fascia. Okay, so in males, we call this all the spermatic cord will all be involved in this area. Okay, and so this is the inguinal canal. Okay, it's a very key point for testicular descent. Now, looking at it in more detail, so we've got the deep internal ring and the superficial ring. And the deep internal ring is sort of more in the inner part of the abdominal cavity, and the superficial ring will be on the external part of the cavity. And the descent of the testes goes through the deep and out through the superficial. Okay, and this is obviously a weak point, as we know, for specific types of hernias. Now, in males, obviously, we get the spermatic cord, and in females, we get the round ligament. Okay, so the round ligament, which will all come through the inguinal canal. Okay. Now, I think we've got a question here which says, what medical problems can occur if the processus vaginalis fails to close off from the abdominal cavity? And we'll open the poll.
Just give it about 10 more seconds.
Mm-hmm.
Okay, I'm going to close the poll.
Okay, so we've got a mixture of D, which is inguinal hernias and hydrocele, and we've got B, indirect hernias. Now, they are both correct in a sense, actually. So we look back at the testicular descent, okay, through the inguinal canal. We know that that's led by the processus vaginalis, okay. So it's going to be, you know, this bit here, okay. The processus vaginalis leads the way, makes the canal, okay. And then the cord is obviously dragged through, attached by the gubernaculum, pulls the testes through, invaginates this peritoneal structure of the transversalis fascia, the internal oblique, the external oblique, and that obviously creates a weak point, which can be exploited. Now, some selected the indirect hernia, which truly can occur from the deep ring, okay, and others selected just inguinal hernias in the hydrocele. So I think I'll give both, but you know, inguinal hernias and hydroceles basically occurs in this weak point. Hydroceles, because obviously if it hasn't been closed up, it gives an opportunity for edema, for fluid to pass through that area as well. And obviously direct hernias usually occur directly through the superficial ring. Okay, great. Now, where is testosterone made in male?
Give it about 10 more seconds. Okay, you close the poll now.
Okay, cool. So majority of people chose A, 1 or 2 people chose D, and the correct answer is A, Leydig cells. Now, Leydig cells and Sertoli cells, they sort of work together, but Sertoli cells sort of provide more of a support, metabolic support, nutritional support, while the Leydig cells, which are more correct, they provide, they produce basically testosterones, okay? So Leydig cells make testosterone. So remember, you do have the LH mainly with Leydig cells and FSH mainly with Sertoli cells, okay? Great. Now let's move on to sex determination. And this is actually quite a key concept to grasp, actually, when it comes to sexual differentiation as well. So we obviously know about the sex chromosomes, XY and XX, okay? And we're just going to go through this in a quite a systematic way. Now, let's start off with males, and we'll probably change this color to blue. And guys, do let me know how I'm doing for time, by the way, okay? So we've got the XY sex chromosome, and the SRY genes, or the sex determination region Y gene, or some people might call it the SORY gene, okay? And that's quite a key thing to hold on to, because there's a very good way of remembering this when I was at medical school. That SRY expression then helps with the sort of creation of the gonad, or the testes in males, okay? And then obviously we've then got the Sertoli cells, we've got the Leydig cells, and spermatozoa. Okay? Now, the Leydig cells make testosterone, and we discussed this in the previous question. And that is quite important when put together or in conjunction with Sertoli cells, which express anti-Müllerian hormones, okay? So we've got 2 key things here, the anti-Müllerian hormone, or the AMH, and testosterone, okay? 2 key things which are important in this sex determination. And of course, we've got spermatozoa. Now, the anti-Müllerian hormone has an effect on the Müllerian duct. And the effect it has is that it prevents it rather from forming. And the end point of that is that there's no uterus. While the testosterone helps the Wolffian duct to form, which causes this male internal genitalia, okay? So AMH and testosterone going back further up with Leydig cells and Sertoli cells, and going even further up, thinking about the SRY gene causes male internal genitalia, okay? Now let's look at the other concept for females. Now, they don't have this sex determination region Y gene expressed, or the SRY or the SORY gene. And so what this causes is the gonad of ovaries, if you want to put it that way, okay? Now we've got the theca cells, and we've got the primitive sex chord, which becomes granulosa cells. And obviously we've got oocytes, which is the opposite of the spermatozoa. Now, of course, there's a little bit of testosterone together with aromatase, which causes this estradiol. So the Wolffian duct degenerates. Yeah, there's no anti-Müllerian hormone, so the Müllerian duct develop, and this causes a uterus formation and internal or female internal genitalia. Now, there's one way that I remembered this, and I will try and see if I can explain it briefly. It's not mine, it's from a lecturer at university. Now, the way I remember it is that SRY for sorry and it's basically the expression of the chromosome saying, sorry, but you're going to be a bloke. Okay, so sorry, you're going to be a bloke. And as a bloke, they say blokes are, and you know, quote unquote stereotypical, more wolf-like, you know, a little bit more aggressive. So sorry, you're a bloke and you're a bit wolf-like, so you have the Wolffian duct formed, okay, and that expresses the male genitalia, yeah, internally. Okay, so sorry, you're a bloke, you're going to be a bit wolf-like. Okay, now we know the brand Muller yogurt, and there's one called Muller Light, and it's very stereotypical, but women prefer Muller Light, okay, because it's low calories, all that kind of stuff. So if you remember Muller Light, you remember Mullerian duct formation, so no anti-Mullerian hormone, and so, you know, they don't have the sorry gene, so they're not going to be a bloke, and they like Muller Light, so Mullerian duct. Okay, hopefully that will help some of you out in the exams. Great, let's move on. So we spoke about the internal sexual differentiation, and this is basically it. You know, we both start off, both male and female, the gonads, the Wolffian duct, the Mullerian duct, mesonephros, and obviously the expression of the anti-Mullerian hormone destroys the Mullerian duct in male and helps to promote Wolffian duct because of testosterone, and obviously in female, without the anti-Mullerian hormone, they have this Mullerian duct formation, and the Wolffian duct degenerates. It's just one of those concepts that hopefully you can grasp. Great. The next question: what hormone determines the differentiation of external genitalia in female? This question might be a little bit ambiguous, so if you do get it wrong, not a problem. I think it's just the way the question was formed. But in other words, which hormone do you think is quite important in external genitalia? And that is the key word, yeah? External genitalia formation.
I'll just give them a couple more seconds.
Yeah.
See people like changing their minds.
Okay.
This poll is completely anonymous. I can just see the numbers going up and down. That's all. Okay, but 5 more seconds. Okay, I'm going to close the poll now.
All right, let's see. B, estrogen. Okay, that is the majority, B. So 50% said estrogen, 25% are saying DHT, and 25% are saying aromatase. Okay, so this can be a bit of a tricky question, and single best answers is about not just what is correct, but what do you think is the most correct. And in this case, in terms of external, that is the key word, external genitalia differentiation, the correct answer is DHT, yeah? Dihydrotestosterone. That is the key hormone that helps with differentiation of external genitalia. Now, in order to have dihydrotestosterone, you need this 5-alpha reductase, which is quite a key thing to hold on to for our next slide. Because when we talk about external genitalia, we have to think about things that could go wrong with the differentiation of external genitalia. Now, what could go wrong? Well, glad you asked. We usually can, this is quite rare, but you know, we do have cases of what's classed as ambiguous genitalia. Okay, and we literally just spoke about the 5-alpha reductase, and if you don't have 5-alpha reductase, you won't be able to produce DHT, which is quite a sort of powerful form of testosterone, changed by 5-alpha reductase, and that helps in the expression of external genitalia. So without that, you can get this ambiguous genitalia. Okay, so common causes of ambiguous genitalia, one that you probably should know if you don't remember any of them, is congenital adrenal hyperplasia. That is probably the most common cause of ambiguous genitalia. Now, note that ambiguous genitalia is the expression, right? The external expression of the genitalia. So in this case, let's look at this case where you have 46XX. They have a not able to have 21 hydroxylase deficiency. Okay, I'll go over that in a minute. So your question, they don't have this 21 hydroxylase, they have this deficiency, which causes high production of ACH in the anterior pituitary, not getting this negative feedback. And so you can get the internally female, if we could say biologically, but you get this ambiguous genitalia. Now, obviously, in 5-alpha reductase deficiency, so internally male, but they can't produce DHT, and so it appears sort of like female or ambiguous. I noticed there's a question. I'm going to go over that. I'm going to go through questions at the end. Let me just move through the actual PowerPoint. Okay. Great. So what is meant by pubertal delay? And there's a slight mistake in this question, but either one is okay.
Yeah, give it about 10 more seconds. Okay. I'm going to close the poll now.
Can I see it? It's question 7. So 50% say A, and 25 saying B, and the rest saying C. No one's saying D. Okay. So A is correct, and of course D also is correct, I realise. There's one caveat here. I think if there's anyone here from the US, for example, or from the Americas or the Caribbean or that side of the world, it'll probably, most of the literature in that part of the world will say 12 years for girls and 14 years for boys. But obviously we're in the UK, and BMJ actually says that it's 13 for girls and 14 for boys. So that's just one thing to remember. Okay. Now, obviously, one of the main things that you need to know when it comes to puberty is Tanner staging. Okay, and it's not something that we're going to go through in this lecture because of time, but it's something that you ought to probably look over. Okay, stage 1 is before puberty, and stage 2 onwards is the beginning of puberty. Okay, we're going to crack on because of time. Now, obviously, we know that puberty is, as it says here, is an interval characterized by the acquisition of secondary sexual characteristics. Okay, it's accelerated, it's linear, and it's where the gonads start to mature and to express that secondary or express sexual characteristics. Okay. And there are many issues or problems that can occur, such as precocious puberty, when someone starts to develop or to show their secondary sexual characteristics before the age of 8. You know, the pattern might not be as expected. You know, basically things can occur in ways out of order or before the time that you would expect it. And most of the times it's to do with what's called the HPG axis. So that's something to just go over if you're not quite acquainted with it. And it's basically H for hypothalamus, P for pituitary, and G for gonad. Okay, so HPG. Just know about the feedback system. Okay, so we know that GnRH, so the GnRH is produced in the hypothalamus, which then causes the pituitary to release sort of, you know, LH and FSH, which then hits the gonads. Okay, so it's going in this form, hits the gonads, which then produces the androgens and estrogen, and you get this negative feedback. Okay, so I would say when it comes to puberty, just have a look on the HPG axis. Okay, that's quite important, and that will help you to think about how problems can occur and where basically the generation of the linear maturation happens. Great. Now we're almost near the end. So what occurs in day 1 of the menstrual cycle? I find that people usually either get this right or get this wrong. What occurs in day 1?
Give it about 10 more seconds.
So you get someone who started now in puberty, they're ovulating, they're having a menstrual cycle, and they want to know which day is day 1. Which day is it?
Closing the poll now.
Okay, wow, this is a split between B and E. And the answer for this one will be B, okay? So the start of the menses, okay? The beginning of the menses, so first day, so that's called day 1, okay? And we're just gonna crack on through it because of time. So just looking at the endocrine system control of female protection, we're not going to spend too much time on this, but I think the next slide explains it really well in terms of menstrual cycle. So the first half is the follicular phase, and the key thing there is FSH, which stimulates follicle. Okay, that's why it's called the follicular stage. And so the dominant follicle is selected. Okay, negative feedback, yeah, is quite important. Suppressing LH and SH, yeah, and estrogen. Okay. And so once estrogen level rises, this negative feedback, only one follicle can survive. Okay, so that's the key thing. Okay, so we're talking about the follicular phase where FSH stimulates this. Then we get in the negative feedback from estrogen, which causes one follicle to survive. Estrogen keeps on increasing, yeah, until you get to that critical threshold. Yeah, and then that critical threshold causes us to switch to positive feedback, okay, and then that activates the pituitary, causing an LH surge. So some people answered LH surge in the last time. That's typically, if you count backwards, day 14. Yeah? So you get that LH surge, and that triggers ovulation, and then you get the luteal phase and fertilization. If it doesn't occur, then you get that the corpus dies, and we're back at the start again. All right. So those are the key things to remember. Great. And we think this is the last one. A 23-year-old girl comes into GP asking for long-lasting contraception. She plans on not getting pregnant for at least 5 years. She doesn't like the idea of hormones. Any suggestion from the list?
We'll just give it about 10 more seconds.
Mhm.
I think most people have answered so far.
Okay.
Okay, cool. Closing the poll now.
Okay, cool. Yeah, so majority suggested intrauterine device, i.e. copper coil. Okay, there's copper is spermicidal, and yeah, I mean condoms definitely. I definitely understand that. So 80% went for this, 20% for that. Makes sense. I mean, it would make sense if she's not really planning on getting pregnant for 5 years or so. You know, it's probably better to suggest a copper coil. But you know, condoms also do work in that sense. So just remember that the intrauterine system actually produces a bit of progesterone. Okay, that's all we need to take away from this slide. Yeah, it's progesterone releasing, and I think that one can crop you up a bit. So just going over the contraceptive sort of methods that you can use. Obviously, just remembering which day is day 1 of the cycle, and also knowing sort of whether if someone sort of like missed their pill, you know, when do they need to use condoms, etc. But that basically is the end of our quick crash session, and so there was a question about DHT, and I think the question was basically why does DHT have an impact on external genitalia, and we'll just go through that quickly. Remember, if you don't have 5-alpha reductase, which is this enzyme here, if you don't have 5-alpha reductase, you won't be able to make DHT, and so you are male internally, but you need DHTs to push through the external characteristic, okay, so that you don't have this ambiguous genitalia, basically. That's basically why you need DHT. So you can look sort of appear female or ambiguous, and then, you know, someone will come into your office, they're not having their periods, for example, you know, and then you realize, well, actually, they're genetically male, but because of the lack of DHT, they weren't able to give that sort of phenotypic appearance of male sort of testes and penis, etc. Okay, I hope that helps. If anyone has any questions, I know we're quite pressed for time, it's quite late, do email the team here, who will definitely provide any response, any slides, anything, you know, we can give an update.
So I've got 4 slides. Basically 2 of them are on the anatomy that I think was covered in this week of the course, and some little nuggets of information to go with them. 1 slide is on dysfunctional uterine bleeding, and 1 slide is on the menopause. So the first slide is about the uterus and the ovaries and some nuggets. So first, the layers of the uterus, 3 layers. You've got the perimetrium, the myometrium, and the endometrium. And if you're getting very detailed, the muscle has 3 layers. So it's got the inner, the middle, and the outer. And then the layers of the endometrium, you've got the basale, the spongiosum, and the compactum. And the ones that are shedded are the spongiosum and the compactum. Then if we look at the ligaments that surround the ovaries and the uterus and the cervix, there's a few ligaments there, but there's sort of 2 key facts that I want you to remember. As Adrian mentioned, the round ligament is the female equivalent of the male gubernaculum. So it follows the same passage. It goes through the inguinal canal and joins the labia majora, like the gubernaculum goes down into the scrotum. And then the cardinal ligament is the one that contains the uterine artery and the uterine vein. So this is blood. key thing here is the different supply, the different blood supply to the ovaries and to the uterus and the vagina. So the uterus, the vagina and the cervix are supplied from the internal iliac artery, which comes from the common iliac artery, and the ovarian artery is supplied by the abdominal aorta, and that's the same with the testicles. And that's relevant either when you're doing surgery on that sort of area or for the spread of cancers. So like with testicular and ovarian cancer, you'll get para-aortic lymph nodes that are enlarged. So hysterectomies, indications for this, most common one I think is cancer, either endometrial, cervical. I think you probably would for some forms of ovarian cancer. Hemorrhage after a C-section and prolapse that's difficult to treat in other ways. And the key fact that always seemed to get told to us in medical school was that the ureters are easily damaged during a hysterectomy, and the relation of the ureter to the uterine artery can be remembered by the phrase water under the bridge, with water being the ureter and the bridge being the uterine artery. So the ureters go under the uterine artery. And then I just put in this little fact about ovarian reserve to remind you that females have their highest ovarian reserve in their mid-gestation. Okay, do let me know if there's any questions. I'm not sure I can see the chat, but that's slide 1 of 4. Says, oh, and now there's a question.
I'll open the poll now.
Thank you.
Give it 5 more seconds. Cool, so I will stop the poll now.
Fabulous. So most people got that. So the round ligament is the equivalent of the gubernaculum. The cardinal ligament's the one that contains the uterine artery and vein. So next slide. So next bit of anatomy, the cervix and the pudendal nerve. So the pudendal nerve comes from S2, 3 and 4, and it contains some of the sympathetic fibers. So the sympathetic fibers are craniosacral, and the parasympathetic is the thoracolumbar. So they come from the like T1 to 12 and the L1 to, I want to say 5. So the pudendal nerve is important for a few reasons. Firstly, it supplies the sensation to the external genitalia, the anus and the perineum, and motor supply to the external ana and urethral sphincter. So you may have heard the little rhyme, S234 keeps the off the floor. So that helps remind you what the motor supply does. And its sort of clinical relevance is that a pudendal nerve block is sometimes used if you're doing surgical procedures in that area, or things like an episiotomy, because it supplies sensation to the perineal region. And to do the perineal nerve block, you want to go just medial to the ischial tuberosity, which is the bit that you sit on. That is a cervix. So you've got the endocervix, the bit in blue, and the ectocervix, the bit in green. The endocervix is alkaline and columnar, and the ectocervix is more acidic, like the rest of the vagina, and squamous epithelium. And where those two cell types join is called the transition zone, and that is where cervical cancer tends to originate. And the key thing to remember about cervical cancer is HPV 16 and 18 cause the majority of cases. I think there are other strains that also predispose you to cervical cancer, but 16 and 18 are the big ones. And warts, genital warts, is 6 and 11, but 16 and 18 for cancer. And the cervical screening program is probably worth just remembering. 25 to 50, it's every 3 years. 50 to 64, it's every 5 years. So, question number 2.
We'll give it a few more seconds. You have a question in the chat as well, Tim. I don't know if you can see it or not, if you want to do them in the end or...
I cannot see the chat.
It's a quick one. I'll read it out to you. It just says, which is more common out of 16 and 18, or would we not need to know?
I certainly don't know.
I don't know either.
I'd say no need to know. I'd say. But great, it looks like everyone got that correct. Yeah, 16 and 18 for cervical cancer. Yeah, I wouldn't worry about that. So this is the third of 4 slides, and it's on DUB, dysfunctional uterine bleeding. So this is the definition here: excessive or irregular premenopausal uterine bleeding, not due to a recognizable cause. I guess due to a recognizable cause is the key bit there. So it's a diagnosis of exclusion. So you have to sort of rule out everything else before you call it DUB. So risk factors for this: certain age groups are more at risk. So immediately after puberty and immediately before the menopause is when the HPG axis is most fragile. So you're more likely to get endocrine irregularities that will predispose you to DUB. And then high BMI, because adipose tissue has a role in producing estrogen. Hi, sorry, I think I disappeared there.
No worries, just reshare your slides and we can edit it out.
Okay. How's that? Okay, so your differentials for DUB, which I think were sort of, I remember being like the biggest aspect of this week. So pregnancy is sort of like something you always want to rule out. If you have a woman of childbearing age with any abdominal or bleeding symptoms, pregnancy should always be on your mind. Iatrogenic causes, so like intrauterine devices, particularly the copper coil, can give you heavy bleeding. Anticoagulants like warfarin, Noax and Doax, heparin. Infections, so PID or pelvic inflammatory disease, most commonly when STIs start spreading upwards. Fibroids, endometriosis, thyroid, both hyper and hypo. Cancers, endometrial cancer being the most common, but also cervical and vaginal. and clotting abnormalities like von Willebrand's disease and haemophilia A or B. So those are the sort of things you want to be ruling out before you diagnose someone with DUB. So your investigations for anyone you're concerned about maybe having DUB, transvaginal ultrasound, and something to remember here is if it's over 5 millimeters, and that's the endometrial thickness. If the endometrial thickness is over 5 millimeters when someone is postmenopausal, that's abnormal and a cause for real concern. So other investigations, you want to do full blood count to see if someone is iron deficient anemia, and just have a think to yourself whether that would be microcytic or macrocytic. That's right, it would be microcytic. You want to do a pregnancy test and a cervical swab for STIs. And your management of the bleeding, so medical, hormonal and surgical. Your medical management, there's two main things that are used: tranexamic acid, which is an antifibrinolytic and is particularly used for bleeding, and then mefenamic acid, which is an NSAID and is more effective for the symptom of pain rather than the symptom of bleeding. Hormonal things that can be used: the Mirena coil and the combined oral contraceptive pill. The Mirena coil is much better at reducing the amount of bleeding. And in terms of surgical options, you've got an endometrial ablation or a hysterectomy, which is sort of a last resort. And these are your red flags that make you think maybe this is cancer. So postmenopausal bleeding, postcoital bleeding, or intermenstrual bleeding. They're red flags. Okay, and then question 3 is quite a wordy one.
Okay, I'm going to share it now.
Okay, so it looks like half of the people went for endometrial cancer and half of the people went for DUB. Is fair enough. So things like well-controlled hypothyroid and the aspirin are sort of red herrings, not to pay too much attention to. In this case, the sort of key thing you need to notice is that she's 68, she's got postmenopausal bleeding, and she's got an endometrial thickness of 14 millimeters. So 14 millimeters is much thicker than it should be and suggests that there's some abnormal endometrial growth there. So endometrial cancer would be the thing that you'd be worried about here. Okay, the menopause, final slide. So definition is at least 12 months of amenorrhea. And in terms of the timings of it, the UK average is around 51. If it happens before the woman turns 40, it's termed primary ovarian failure. And some things that affect it, so family history, and in particular the genes BRCA1 or BRCA2 mean that the menopause typically happens earlier. The age at which the woman goes through puberty, so the earlier that happens, the earlier they tend to go through menopause. Smoking tends to bring the menopause on earlier. Chemotherapy and a low BMI. So hormones, I think, is all very complicated, and I'm certainly not an expert, so I'm not going to go into any detail at all, because it would take a while and I might get it all wrong. But I think one of the key things to remember for exams is that your low AMH is the first sort of easily testable sign. So some of the symptoms that women get as they go through the menopause, the first two I've got down there are caused by low estradiol. So firstly, that can cause urogenital atrophy, which gives painful sex or dyspareunia and can give bleeding as well. And it also causes, low estradiol also causes a reduction in bone density, not immediately, but over a few years. I think 3 to 5 years, people typically say this becomes like a greater risk, and fractures, classically a neck of femur fracture, and hot flushes is also another symptom. And one way of treating that is HRT, or hormone replacement therapy, which consists of 1, maybe 2 things. So it always has estrogen, excuse me, and then you also must add progesterone if the woman has a uterus. And the reason you do that is because unopposed estrogen causes endometrial hyperplasia and makes endometrial cancer much more likely. But if they don't have a uterus, you shouldn't add on progesterone. I think we were told that the ideal combination is an estrogen patch and Mirena coil. I think that comes with the lowest risk of strokes and other, yeah, it's sort of the lowest risk combination of getting those hormones. So things that HRT puts you at increased risk of is breast cancer, ischemic heart disease, and then clots, so PEs, and cardiovascular, CVAs, cardiovascular accidents, strokes basically, and lower risk of colorectal cancer and hip fractures. And the hip fractures sort of comes from what I was saying earlier about the low estradiol causing a reduction in bone density. For the first 2 or 3 months that a woman's on HRT, you can get unscheduled and irregular bleeding. And now I think the final question. So which of these factors isn't related to an earlier menopause? Smoking, BRCA2 gene, multiparity, low BMI, or chemotherapy?
There's also another question in the chat for you, Tim, which I'll read it out. You can answer later or now. But it's, does low AMH cause depletion of follicles, or is it vice versa?
So I think it's sort of a combination. So as your follicular reserve gets lower, you produce less AMH, which means you produce more FSH, which means that you recruit more follicles. So I think like your low follicular reserve predisposes you to producing lower levels of AMH, and then your lower levels of AMH also mean that you recruit more follicles, so your level of follicles drops. But also I'm really not an expert on this, so I wouldn't take what I say as gospel.
I think you could.
Sick, thanks.
I'll give a couple more seconds because I know we have a few people who haven't answered yet, but maybe I'll give. Okay, I'm going to close it now. Oh, the person answered just as I went to close it. I'll give you a few more seconds. Okay, they've decided. Stop taking it out.
Okay, so I think the answer to this is low BMIs. I think, oh, sorry, no, multiparity. Sorry, low BMI is related to an earlier menopause. and multiparity is not. I think if anything, nulliparity is, but I don't think multiparity is associated in any way with an earlier menopause. So that is everything. Good luck if you have exams coming up. I remember feeling extremely nervous and stressed when I was in your position, so I hope you will do very well. And that is it.
So hi, I'm Melissa. I am a GP trainee, and I have to give credit to Ellie Pierce, who's another doctor who prepped these slides for me, and I've just adapted them to some of the things I wanted to talk about today. So let's start with an SBA, and I'll just keep an eye on the group.
Also, I've opened the poll. Give it about 5 more seconds. Okay, I'm going to close the poll now.
So I think most of you went for the majority, which was increases. Yep. So the temperature increases due to progesterone production, and we'll come to that in a second. I've got a second SBA as well before we talk a little bit about pregnancy.
I've opened the poll. Just give it about 10 more seconds. Okay, I'm going to close the poll now.
Yep, so all of you chose the correct one, which is the ampulla. So we have touched upon the menstrual cycle quite a bit. Oh, I had another diagram that's not come up, but essentially it's just a really quick zoom through thinking a bit about pregnancy in the early stages of pregnancy. So you have your follicular phase, which we talked about, where you have a rise in the FSH, which causes stimulation of the ovarian follicle. The dominant follicle, or what's known as the Graafian follicle, then produces a large amount of estrogen, which in turn inhibits the other follicles from developing. And as the Graafian follicle continues to secrete estrogen, the endometrium thickens and the cervical mucus thins to allow passage of sperm and inhibits LH production from the pituitary gland. However, as estrogen levels rise, this actually produces a positive feedback loop, and there's a surge or a spike in LH around day 12 of the cycle. In a 28-day cycle is what we're talking about here. And it's during that surge that the follicle ruptures and a secondary oocyte is released. This leaves behind a corpus luteum that then produces progesterone. And progesterone allows the endometrium to be more receptive to implantation. It decreases LH and FSH levels and physiologically increases body temperature. So if fertilization occurs, the ovum produces HCG, which in turn prevents degeneration of the corpus luteum and allows for ongoing progesterone production, which the placenta then takes over this role from about 8 weeks. So fertilization is essentially the process of sperm entering the ovum, where 2 sets of genetic material fuse together and result in a zygote, which is a single diploid cell. So this usually takes place in the ampulla of the fallopian tube. And a zygote contains 23 chromosomes from the ovum and 23 chromosomes from the sperm. And this then undergoes mitotic division, where the embryo then has 2 cells on day 1 and then continues to divide. So mitotic division continues, and each cycle takes about 12 to 24 hours. So when the embryo has about 16 cells, this is usually about day 4 or day 5. You can call it a morula. And then a blastocyst is formed as the cells start to organize and differentiate. So I had that process along my slide, but unfortunately it's not come up. But there's a more detailed production of a blastocyst there, which we'll talk about in a moment. Oh, okay, there we go. So 5 days after fertilization occurs, the blastocyst has approximately 100 cells within it, and there's a window of implantation which is around day 5 to day 6 after ovulation occurs and lasts for about 24 to 36 hours. So within the blastocyst is a layer called the trophoblast, which is the outer layer, and it's this layer that implants into the endometrium. And there's a few layers within the trophoblast, and one of those is called the syncytial trophoblast. So that's just that outer layer. I don't know if you can see that's just the outer layer here that we're talking about. So the blastocyst adheres to the endometrium using integrins, which are cell adhesion molecules. And once they are adhered, the trophoblast basically secrete enzymes that digest the endometrium and allow itself to bury itself into the tissue. Now, while that process is happening, the inner cells, which are known as the embryoblast, develop. The embryoblast forms the embryonic disc, and then the embryonic disc eventually forms the amniotic cavity and the sac. So around day 7 to 8, the embryonic disc becomes the epiblast and the hyperblast. So the epiblast forms the germ cells, and the hyperblast forms the yolk sac, which plays an initial role in circulation and nutrition. And then the syncytial trophoblast, which we talked about, produces beta-HCG, which, like we said, maintains the corpus luteum and ongoing progesterone production. This is a little diagram to show that we've got the epiblast and the hyperblast. So we've got a 2-layer structure here within the blastocyst, which is attaching itself into the endometrium. We'll come back to that picture in a moment. I've just got another SBA.
I'll give it about 10 more seconds. Cool. Closing the poll now.
We've got a mixture. So we've got a mixture between B and D. So the endoderm makes the lining of the GI tract, respiratory tract, and the urogenital tract. So I remember it as endoderm, which is the inside lining of things in the body. So essentially what we're talking about is the process of gastrulation. So at around 17 days after fertilization, a band of cell migrates from the epiblast and form a linear band called the primitive streak, which we've got here. And then gastrulation starts from this. So basically we go from that 2-layer structure, which we talked about earlier, into a 3-layer structure. So the epiblast becomes the ectoderm, and then the hyperblast becomes the mesoderm and the endoderm. So ectoderm, we think about outside skin, brain and CNS. The mesoderm is M for muscles, so heart, skeletal muscles, kidneys, things like that. And then the endoderm, which we talked about, was the lining of the inside things. That's how I tend to remember it. And essentially what this does is it orientates the embryo into head to tail, front to back, and it gives you that bilateral symmetry. And then as that process is happening, you still get your developmental and formation of the placenta, which is fully formed around 13 weeks. Well, another SBA.
I'll give it about 10 more seconds. Okay, closing the poll.
Yep, so I think everyone got that one correct. So first trimester is 1 to 12 weeks, second is 12 to 26, and third is 27 to full term. So full term would be 37 to 42 weeks. So thinking about the symptoms of pregnancy, so we would initially think that the periods would stop because we're not having the menstrual cycle happening anymore. Nausea and vomiting is very common early in pregnancy due to a rise in beta HCG. You get increased urine production because the plasma volume increases, but also later on in the pregnancy you get increased pressure on the bladder. You get increased fatigue and breast tenderness because of rising levels of estrogen, and you would expect to feel fetal movement. So depending on if it's your first pregnancy or you've had a pregnancy before, if you've had a pregnancy before, you may then feel the movements earlier on in the pregnancy. So thinking about some of the physiological changes in pregnancy, I like to group it into systems because that makes it easier to think about. So in terms of cardiology, your blood pressure falls in the first trimester until about 20 to 24 weeks, and then slowly goes back up to what the pre-pregnancy levels were by term. And that usually happens because of a process of vasodilation. Having said that, there's still an increased demand because of placental circulation. So actually, despite a fall in blood pressure and vasodilation, you get an increase in cardiac output and stroke volume. You can also get an increase in your tidal volume due to the progesterone, and that's because there's an increased peripheral CO2 metabolism, and your respiratory center lowers the threshold to kind of kick off when there's a CO2 increase, and that can increase your vital capacity and your tidal volume. Plasma volume increases by about 50%, and that can therefore cause a dilutional anemia. You can get a moderate leukocytosis. So the pregnancy levels for your FBC are slightly different to someone who's not pregnant, but it's just something to be aware of in practice. There's an additional demand for iron, and some clotting factors and fibrogen increases, while fibrinolytic activity actually decreases. So that's the mechanism to protect mum from hemorrhage, but also then increases the risk of VTE. In terms of your GU, so your uterus increases in size and weight, and the muscle increases, as does the blood flow. The cervix hypertrophies, and you get a production of a mucus plug. And then the vagina increases lactic acid production, which lowers the pH to help prevent infection getting through. Thinking about your endocrine things, so an increased progesterone can cause smooth muscle relaxation, which is what you want when you're trying to deliver a baby, so it's easier and your muscles and ligaments are more relaxed. But on the extreme end of that, women can then develop pubic symphysis dysfunction, which can be very painful and debilitating in pregnancy. And like we said, progesterone can increase your body temperature. Estrogen helps with breast development, but can also cause water retention and protein synthesis. And then there's a hormone which is produced by the placenta, which is human placental lactogen, which is like a growth hormone, but essentially a decrease in maternal insulin sensitivity, but therefore increases blood sugar levels, blood glucose levels, which can cause gestational diabetes. Your breasts develop actiferous ducts because you're getting ready to breastfeed at the end of pregnancy, and that is led by prolactin, which can cause lactation. And then because of the hormones that you have an increase in pregnancy, you can get increased pigmentation as well. We talked about an increase of nausea and vomiting in early pregnancy, but again, taken to the extreme is hyperemesis gravidarum. You get a decrease in the sphincter tone, which can lead to reflux, and a decrease of gastric motility, which can lead to constipation. Your kidneys increase slightly in size, and the blood flow increases to your kidneys. The smooth muscle in the bladder can also relax as well because of everything else is relaxing, and which gives increased capacity, but then can also increase the risk of stasis and infection. So thinking about the maternity care timeline, so women usually book around 8 to 12 weeks. And within that booking appointment, they'll be seen by a midwife who will assess different risk of different things. So they'll think about physical health, mental health, and social health as well. Within that, they'll do baseline measurements of height, weight, blood pressure, blood sugar. They'll take some blood tests, including bloodborne viruses and blood group, and they'll think about mum's mental health as well. Then you would expect that mum would go for her dating scan between 8 to 14 weeks. And within that, you would estimate baby's estimated date of birth, and look at the nuchal translucency, which ties in with the trisomy screening. So we screen for trisomy 13, 18, and 21. And alongside that, we do 2 different blood tests as well. So we do a beta HCG and a PAP-A. So if the HCG is high, or the PAP-A is very low, or the nuchal translucency is thickened, that gives an increased risk of Down syndrome. And then as the pregnancy progresses, mum would continue to see midwife or the medical team, and they would monitor fetal movements and the growth of the bump and consider plans for labour and delivery. In terms of thinking about bumps, so measuring symphysis fundal height, so at 20 weeks you should be feeling the womb at the umbilicus, and it should match the gestational age plus or minus 2 centimeters. So if mum is 24 weeks, you should be 22 to 26 centimeters. So we've got another SBA.
Give it about 10 more seconds. Okay. Oh, people are changing their answers. Okay, I'm going to close the poll now. There you go.
Oh yeah, lots of mixed answers on this one. Okay. So I think the majority got it. So yeah, option B. So that's where you take the first day of the menstrual period, add on 9 months. You can either add on 12 months and -3, and then add on a week. So essentially that's something called Nigel's rule, and it basically assesses for 280 days or 40 weeks as the EDD. I've got another one actually as well.
I'll give it about 10 more seconds. Oh, last person just got in, so I'll close the poll now.
Oh, we had that's an interesting one. Yeah, so you're right. So B and D are very similar, but the way that we would define second stage of labour is from full dilatation to delivery of fetus, just because delivery of fetus can then be a bit ambiguous in terms of first stage and second stage, which we'll talk about very quickly here. So essentially full-term birth is from 37 to 42 weeks of gestation, and we will classify labour as painful regular uterine contractions. That's how it's defined. So if they're not having that, then they're not in labour. And essentially stage 1 is where the uterus effaces, becomes thinner, and then dilates up to 10 centimeters, which is full dilatation. And you can split that again into latent and active. So latent would be, well, there's initial effacement and then up to 4 centimeters. And then active is when it's from 4 centimeters to 10 centimeters dilated. And basically how it works is the cervix stretches due to pressure from the baby coming down. The pituitary gland makes oxytocin, which stimulates uterine contractions. The placenta then releases prostaglandins, which also cause uterine contractions. And basically it's a positive feedback loop to cause cervical stretching until you get a 10 centimeter dilation. And you would expect to have roughly, depending on whether you're a first time, delivery or you've delivered before, roughly 1 centimeter per hour is what we would look for in a partogram here. And then, like we said, second stage is full dilatation of the cervix to delivery of the fetus. And again, it varies between whether you've had children or not. So for a first time mum, we would say average is 1 hour, but we would give up to 3 hours before we decided to think about adding in some help. Or in multiparous women, 30 minutes is roughly the average, but again, we would give up to 2 hours before adding in some help. And then stage 3 is basically the delivery of the placenta. So you can do that as physiological, or you can do it as active management. So physiological is when you just let things happen naturally, and active is when you give an IM injection of symptometrin to help the uterus clamp down and contract. And that would be discussed before labour, because you need to look at people's risks of postpartum hemorrhage. This is our second last SBA, and then I'm going to do a quick whiz through postpartum, and then I'm done with my bits.
We'll just open up the poll. Okay, I'll give it about 5 more seconds. I think everyone's answered. Okay, closing the poll now.
Oh, good mix. Okay, interesting. So I'll talk a little bit more about this in the next slide, but the most common cause is actually uterine atony. And I think I've got one more SBA, which is a bit more a spiel question, so thinking about mental health.
Okay, just give it about 5 more seconds. I think everyone's answered anyway. And I will. Oh, okay. Suddenly got more people answering. Cool. I'm going to stop the poll now.
Yeah, so majority went with baby blues, and I'll talk about that in a moment as well. So just a quick whiz through about puerperium. So that's the postnatal period, which is from birth to 6 weeks afterwards. So hormonally, you would expect that things like the human placental lactation will fall, and that will help resolute the gestational diabetes that some women can have. The uterus, as soon as you give birth, actually goes to a 20-week size and then reduces for the next 12 days back into the pelvis. And alongside that, you would get lochia, which is initially fresh red blood for the first 3 days, and then more reddish brown from day 3 to day 12. Vagina regains tone, and you get decrease of edema that can happen during delivery, and the cervix closes within 10 to 14 days, but remains permanently changed in shape. So if you have a look on a speculum examination of someone who's delivered, you can see that it looks slightly different if you keep practicing. Hemodynamically, the cardiac output, the blood pressure, and the peripheral resistance goes back to normal in 2 weeks. However, you have increased clotting factors which remain for 6 weeks, and actually the risk of having a VTE is the highest in the postpartum period. So it's 20 times more risk than someone who's a woman who's not pregnant, for example. In terms of breastfeeding, so you in the first 48 hours you get colostrum development, and then you would expect that after day 2 your breast would become more enlarged and you would get milk coming through. So there's a fall in estrogen levels, and basically that removes the negative feedback, and the prolactin levels rise, and the sucking motion of baby releases oxytocin, which can help the milk ejection reflex. And just thinking a little bit about the pros and cons of breastfeeding, which I've put there, but I won't go into very much. So like we said, the puerperium is the 6 weeks after birth, where a woman's body returns to its pre-pregnancy state. A woman is actually most likely to die after birth. And the main causes that we think about are hemorrhage, which is the main cause worldwide, sepsis, and VTE, which is the main cause in women. So thinking a little bit about hemorrhage and postpartum hemorrhage. So postpartum hemorrhage is defined as a blood loss of 500 mils or more, and you can get primary or secondary. So primary is within the first 24 hours of delivery, and secondary is from 24 hours up to that 6 weeks postnatal. And we think about our 4 causes, so tissue, trauma, thrombin, and tone. So tone, where you have uterine atony, so it's not contracting well, accounts for 80% of causes of primary PPH. And the way that you deal with that is that you apply pressure, you apply tone on the uterus to help it contract more, and then you can give uterotonics additionally to help that uterus contract more. Trauma, we're talking about things like lacerations, vaginal tears, episiotomy things. Tissue, we talk about retained products of conception. So this can actually present immediately, or sometimes some women come back with an increased bleeding after they've gone home after the first 24 hours, for example. And thrombin, we think about underlying disorders of clotting. So haemophilia, or women who are using low molecular weight heparin because they have a risk of VTE and then they suddenly bleed more because of that. And if anyone presents with a symptom of VTE in postnatal period, you have to take it really seriously and investigate them urgently. In terms of secondary causes, you can also think about endometritis, which is an infection of the endometrium. So again, it's a classic story of the bleeding gets better and then actually suddenly women present to the maternity triage and the bleeding gets worse again. In terms of mental health, so you can use the Edinburgh postnatal depression screen to assess it. Baby blues can be seen in around 60 to 70% of women, so it's very common and typically presents within the first week following birth, and more common in women who are primates. Basically, they're typically anxious, tearful, and just need some reassurance and support from the health visitor and yourself. Postnatal depression can affect around 10% of women, and most cases start within a month and typically peak at 3 months, and it's similar to the features of depression that you would see in any other patient, and the treatment doesn't really differ either. So you think about cognitive behavioral therapy, and you think about your SSRIs depending on what the woman wants and their breastfeeding status. And then puerperal psychosis can affect 0.2% of women and usually starts within the first 2 to 3 weeks following birth, can include severe mood swings, disordered perceptions such as hallucinations, and they need admission to a hospital, and more specifically a mother-baby unit. And the reason it's important to know about is because there's a risk of reoccurrence to 25 to 50% in the following pregnancies. So I think that is me with a hopefully quick run through of pregnancy. Feel free to ask or email in any questions, and good luck with exams.
Okay, so hi guys, I'm Aj. I'm an F1 doctor in North West London. So I'll be covering Down syndrome and developmental disorders today. Just a disclaimer, everything that I am saying is basically from all the references I've listed below and just kind of put the content together. And so please do check with your own stuff and your local guidelines as well if you're not from George's or even from the UK, because I've noticed we've got a few people who aren't from the UK. And my slides won't move. Oh, there we go. Cool. So just a quick outline of my session. I'll be covering developmental milestones and clinical features, factors leading to developmental delay, going over the basics of kind of the genetic stuff, so like cell replication, DNA structure, the production of gametes and all that. Very briefly, I'll go through karyotyping and the different techniques used, and then go through Down syndrome, the screening, which Elise has actually gone through very briefly in her session as well. And then I've listed a few of the common syndromes as well. Okay, so we'll be starting off with an SBA. So we've got a mother who brings her 12-month-old baby for a checkup at the GP because she is concerned about his development. Which of the following would be a cause for concern? Okay.
I'll stop the poll now.
Cool.
Also, I'm guessing everyone else can see the slides because I can't, but I think it's my computer.
Yeah, please do let me know
if people answer the question. I'm guessing they can see it.
They must,
but
yeah.
Type in the chat if it's not just my computer. You can?
Yeah, I can.
Okay, good. I'm glad it's just me.
Cool. So you can see about 75% of you answered D, which is correct. So the fact that he's 12 months old now, it's a bit too early for them to have a preference at this age. Usually children begin to start using words like mama, dada, and things at this age, and they start creating these 2-word sentences more around the age of 2. The fact that he's not walking unaided and holds onto furniture is appropriate for his age. If he was about 18 months old, it would be a red flag. If he becomes distressed when the mum leaves the room, and if he's got a bit of stranger anxiety as well, which begins around 6 to 8 months, that's normal as well. And then the last option is he's unable to name some objects, as mum points out. That's normal. Okay, so the main principles of development is basically a continuous process where they kind of just monitor the sequence of developmental events just to kind of set a normal standard, but every baby is different and they have their own rate at which their development occurs, and there's just certain limits which are expected, but there's nothing set in stone. And if anything does worry you, just kind of keep monitoring them unless it's a real major big red flag. So I've listed the red flags here. So at any age, if a parent comes in with a child and the presentation doesn't really match with the development, if there's any signs of asymmetry early on or any regression, then you should try and figure out what's going on there. Around 10 weeks, they should have developed a social smile by that time. So if there's no social smile, so just kind of recognizing faces and smiling in general when there's people around, then that's a cause for concern. At 6 months, if they've still got their persistent primitive reflexes, if they have no interest or any kind of reaction to people, any other noises, and if they start showing a hand preference, that's something to worry about. Around 10 months, if they're not able to sit up on their own and they require support, so either you holding them up or kind of sitting them in a chair, then that's another cause for concern. And by 18 months, if they're not walking, they're not saying words. At 2 years, if they're not creating phrases, and by 4 years, they should be able to have basic speech. And then if they aren't able to, and if their speech is unintelligible, then that's something that you'd be worried about too. Okay, next SBA. So you got a mother who brings in her 2-year-old boy to the GP. She expresses concerns that he hasn't started walking yet. He's able to stand but cries to be picked up or prefers crawling. His sister started walking independently at 15 months. He is verbalizing with 2-word phrases and scribbling on the frozen colouring activities on the kiddie table in the room. What is your management plan?
I'll give it a couple more seconds. Oh, actually, I think that's everyone.
I think it.
Oh no, there's more. Ooh. Okay, I'll give it 5 more seconds. Okay, closing it now.
Okay, so there seems to be a bit of a split here. So between A and B, 60% said A and 40% said B. So the correct answer is actually B. So he's not really started walking yet at this age. It's not that concerning, but since he's actually able to stand, it might just be a preference of not wanting to walk. but it is a red flag at this stage, so you should investigate it. So the key thing you want to investigate for is muscular dystrophy, and the blood test for that is creatine kinase, which screens for this. So the question here is it's your kind of first instinct here. You might want to then consider physio referral once you've got a clear diagnosis, and you'd also want to check for any kind of hip abnormalities and maybe refer them to orthopedics for possible interventions they may need. I think that's all I have for that one. Yeah. Cool. And then I just put this in because this is from the Oxford Handbook, and it's quite useful because it just gives you a clear-cut outline of what you expect at each kind of developmental milestone. So as I mentioned before, 6 weeks is a smile, 4 months, 6 months just kind of sitting up, able to reach out for things, kind of moving things between their hands. And then if you go down to like 1 year, they start saying certain words, like mama, mummy, and daddy. 18 months, this is where they can start walking, start scribbling, kind of start putting things together, like building a tower. And then by the time they're 4, they should be able to walk around, talk, stand on 1 foot, for example. They should be able to just dress themselves very basically by that age as well. And then this is another assessment that you guys should know about. So the Griffith Mental Development Assessment. So it's widely used by paediatricians and psychologists to measure the rate of development in infants. So it goes from birth to about 8 years, and it assesses the child's kind of strengths and weaknesses in all the different areas. So looking at their kind of gross motor skills, their fine motor skills, their personal and social skills, assessing their hearing and their language skills as well, their sight, and then hand-eye coordination, just general performance through different tasks and how fast they work and their precision, and just in general like practical reasoning once they're a bit older, and just to kind of see how they solve problems just in their natural environment as well. And if there's any concerns, then they can just intervene early on and start a treatment program. Okay, I just had to put the little animation in there. Cool. And these are just a few factors which may affect development. So key things to remember is like any genetic factors, any nutritional factors. So things like deficiencies in vitamin D, iron, for example. Any health conditions, so got your trisomy 21, Prader-Willi, Fragile X, any other chronic illnesses they may have, so things like cystic fibrosis, for example. Environmental factors and opportunities, so their home environment, for example, if they're growing up in abusive homes, if they've been neglected, if they were born prematurely, for example, as well, lack of stimulation, exposed to any toxins as well, and the maternal factors here as well, they might have any attachment issues there, and also if the mother was either abusing alcohol or drugs whilst pregnant as well. And then there's also idiopathic causes too. I can see the question here about, what is it, Edwards and Patal's. I will be coming on to that later on. So I'm not going to answer that just right now. Cool. Okay. So just moving on to the basic structure like DNA and chromosomes in general. So for cells to divide, it requires the chromatids to be highly compact. And so sometimes you get questions, especially in the preclinical years, just asking very nitty-gritty details that you wouldn't really think about remembering. But this diagram here, which you'll have access to after the session, has a few numbers in there, which I would just kind of try and remember, because sometimes you'll have those little niche questions in there which might just score you a point. But just to kind of go through what actually happens. So the chromatid is basically a double-strand structure of the DNA itself. This then forms complexes with histones, so specifically 8 histones, which forms a nucleosome, which wraps around exactly 1.65 times. I remember that coming up in one of the practice questions I did, and it just really annoyed me. And then these chromosomes then consist of nucleosomes plus a histone, which then folds up, and these continue to start kind of spiraling and start compressing into fibers, which eventually produces the chromatid of a chromosome. Okay, got the next SBA here.
Give it a couple more seconds.
Yeah.
Also, I'm gonna log out quickly after this and join back because mine's still not loading properly.
That's fine. I think I should be able to
Right,
pulse.
yeah.
Yeah.
I think it's probably better if I do it now than later.
Yeah, that's fine.
Cool. Give it 5 more seconds. Okay, I'm gonna stop the poll now.
Okay, so I can see people have picked A and B. A majority have picked A, which is correct. So, oh, what's that? Okay, so it is, so when the P and Q arms are of equal length, it is metacentric. I'll go over these ones. Acrocentric does not exist. I just put that in there to trick people. Okay, so this is your chromosome here. So you've got your long arm, which is known as a Q arm, and you've got your P arm, which is also your short arm. And in the middle, you've got the centromere, and there's a kinetochore there which connects them all. And this basically allows the 2 sister chromatids to attach to each other. So metacentric is when this centromere is in the center, so in the middle. Submetacentric is when it's slightly off center, so the P arm becomes a little bit shorter. Acrocentric is when it's a lot further along the chromosome, so the P arm's a lot more shorter. And telocentric is when that centromere is right on the end. And these telocentric chromosomes don't actually exist in most animals. I think there's just certain plant species, from what I remember, that they exist in. Definitely not in humans. Okay, and then just key terms that you need to remember are haploid, which means a single copy, diploid, which is your 2 copies, polyploidy, which is when there's multiple copies, so diploidy, where there's 3 copies of each chromosome, and then aneuploidy is when there's an extra copy of, or a missing copy of just 1 chromosome. So it means you don't have to get the exact number. So for example, trisomy 21, where you just have that extra chromosome 21, and gives you a total of 47 chromosomes. So in humans, we have 23 pairs of chromosomes, 2 are autosomes, and you have 1 pair of sex chromosomes. So in total, you should have 46. Okay. So the next SBA. So during mitosis, at which stage do chromosomes separate to opposite cell poles. I'll just open up the pole now. I'll give it about 5 more seconds. Okay, I'm going to close the poll. So everyone answered C, which is correct. So well done. Okay, so in interphase, you've got the chromosomes unraveling. By the time you get to prophase, this is where all the genetic material becomes duplicated. And then you have this kind of intermediate phase, which is your pro-metaphase, where the nuclear envelope itself in the nucleus breaks apart and the mitotic spindles start coming and attaching to the kinetochords. So those complexes at the centromere of the chromosomes. So it attaches to that. Metaphase is where these genetic materials kind of condense into the chromosomes. And by anaphase, these pairs of chromosomes attached basically get pulled to the opposite poles of the cell. And this allows the next stage to happen. So telophase, where this separates the duplicated material and forms that new nuclear envelope. So you get 2 identical nuclei. And then the last stage is cytokinesis, where the cell actually divides and all the organelles divide up into 2 separate cells. So essentially, your nucleus multiplies first, and then the cell itself divides afterwards. I've just kind of put this in here because I thought it would be a quite useful diagram as well. So chromosomes itself, so as I mentioned before, it's got the centromere here, which is the key bit. And this is also key later on when I start talking about mitosis and meiosis for recombination. And the other little bits that you need to know, which I'll be talking about in a bit, is the light and dark bands. And the light bands replicate early on, and then the dark bands replicate later on. And the light bands are more rich in G and C, and then your dark bands are more rich in A and T. And that's it, yeah. Cool. So in terms of the production of gametes, so it follows the pattern of mitosis, which we just went through, but it's a process called meiosis, where it goes through the cycle again. The only difference is during prophase 1, which is this stage here, you have this kind of tetrad of the chromosomes forming, and this allows the crossover of your genetic material to allow for that differentiation that we see in humans. And this process is called recombination. And then I put this diagram in here, which just compares both mitosis and meiosis, and just shows the end products here. So for mitosis, you just get 2 daughter cells with 2 pairs of each chromosome. You can see that there. And then in meiosis, at the end, you get 4 daughter cells with single chromosomes, so half of what you'd have in the end product of mitosis. So each cell at the end of mitosis will still have 46 chromosomes, whereas in meiosis it will have 23. And the purpose of this is when the egg and the sperm fuse, then it will have a total of 46 at the end to form the embryo and then your little human afterwards. Okay, so just going to quickly go through chromosomal abnormalities that you need to know. So Non-disjunction is when the sister chromatids fail to separate during the anaphase stage of meiosis. So it could be anaphase 1 or 2. And the result of this here you can see, so this is your normal meiosis where you get one chromosome. This is just looking at just one particular chromosome. You get one each in each cell. Here, if it's in meiosis 1, so the subpart of that is anaphase 1, you get both of them still in this cell. This cell is empty, so when that divides, you get 2 empty cells with nothing there. Here you have 2 each, so you end up with something that's diploid. Or you can have it occurring in meiosis 2, so your anaphase 2 of that, where it separates out initially, and then this here has separated properly, so you get 1 each there. On this side, when that doesn't separate properly, so you get 2 in this one, and then no chromosomes in here. And usually what happens with these cells, if they're not compatible with life, those just kind of get killed off within the body. The next one you need to know is your Robertsonian translocation. So typically, the ones that are viable with life are with 2 acrocentric chromosomes. So essentially because the little bits of genetic material on these P arms here don't hold that much information, which is critical for life. So these basically join at the centromeres, and this typically happens during like recombination. Sometimes it can happen during mitosis too, but it's very rare. These fuse and form this really long chromosome, forming a new P arm and a new Q arm, and that's essentially can form like a metacentric or another acrocentric or submetacentric Robertsonian translocation, depending on the length of each of the chromosomes itself. And then this slide here, so this one's looking at your trisomy 21 with the Robertsonian translocation. So this is your normal cell, and get your normal gamete here. This is a carrier where they have a Robertsonian translocation, where they've got the long arm of the 14 and the long arm of the 21 chromosome, and both these has most of the genetic material for each of the chromosomes 14 and 21. Therefore, the person carrying this doesn't actually get affected. Whereas whatever these offspring is down here may or may not get affected. So these are the possible different gametes you'll get from this carrier. So you can get just the Robertsonian translocated one from here. It combines with the normal gamete from a partner, and you just get another carrier. So technically you got 45 chromosomes in there, but this is compatible with life, and the actual phenotype will be a healthy offspring. This one here there's a chance of forming a normal gamete as well. So again, you get 46 at the end. Here you've got your translocated chromosome, so your Robertsonian translocated chromosome, plus your normal chromosome 14. So you've got 2 copies of, you've got 2 copies of your chromosome 14 in there, combined with your normal gamete. You got 3 copies of chromosome 14, and then just 2 copies of your the long one is the 14, the short one is 21. Got it the wrong way around. Yeah, so this is why it's your trisomy 21 with a Robertsonian translocation. So you got 1, 2, 3 of your chromosome 21 in there. Monosomy, so that's when there's only 1 of those chromosomes. For this one, it's lethal. trisomy 14 is lethal, and then monosomy 14 is also lethal. So these three here aren't compatible with life. Okay, so the other concept you need to know is mosaicism. So this is when there's a bit of a lag in your anaphase, and then it causes a delay in the movement of the chromosomes themselves. That means sometimes some of the chromosomes don't always migrate to the poles of the cell, and that means the chromosomes don't always separate equally. But this doesn't happen with every single cell, which is why you get this kind of mosaic kind of effect. So some of the cells may have some sort of chromosomal abnormality, for example, trisomy 21. Some of the cells may just have the right number of chromosomes in there. So some of the causes here are early mitosis in embryogenesis, any non-disjunction in mitosis as well. So the one I mentioned was anaphase lag. And the phenotype, so the actual outcome can differ depending on the severity of the mosaicism and how the percentage of cells which have that chromosomal abnormality. Cool. So I'm going to just quickly go through the karyotyping. So you don't need to know a lot about it. You just need to know how each of them works on a basic level. So G banding, it basically looks at the actual chromosomes themselves and the structure of it, and you visualize it. So you stain them, and then you can look at the condensed chromosomes to identify any diseases based on the size of the chromosomes compared to what it's expected to be. You can look for any translocations, possible deletions or insertions if they affect the size enough as well. FISH, so your fluorescence in situ hybridization, detects the location of specific DNA sequences on the chromosomes, and it looks at it during interphase or metaphase specifically, and it allows for you to understand specific genes or portions of genes which might be abnormal. And then you've got your quantitative fluorescence PCR. So this basically detects a number of chromosome copies, and it uses this method of amplification to repeats the sequences to determine the presence of the different alleles as well. And then your array comparative genome hybridization, so array CGH, is more of a molecular technique, which is a lot more technical. So I don't quite understand how it works, but it's mainly used to kind of detect smaller abnormalities, especially like any genetic mutations in things like cancers or any other genetic disorders someone might have. It uncovers like more minor deletions, any kind of break points or anything in the chromosomes themselves. And then I just kind of put this image in here, mainly for the G banding, where you can actually visualize the chromosomes, and you can see how it highlights the light and dark bands in the chromosomes themselves. Okay, so just going to quickly go through Down syndrome. We're almost near the end. So Down syndrome, it's also known as trisomy 21, and the correct terminology for this is trisomy 21 now. It's the most common and frequent cause of physical and mental handicap, and it's got a prevalence of about 1 in 700. And the average life expectancy for someone with this is about 50 years. Doesn't mean they won't live any longer, but it's just the average life expectancy. And the risk factor for this is generally any kind of maternal age of over 45, or if they've got any other kind of issues going on as well. So in terms of the features of someone with trisomy 21, so you got the physical characteristics, and these are the key ones which I've listed here. So you get this kind of simian crease on your palm. So just like one crease on the palms, whereas if you kind of fold your hands, you'll have a lot more creases in there. You'll have something known as the sandal gap, or sandal toe, where there's a larger gap between your first and second toe. They have this sort of flat facial profile with like this broad nasal bridge. They have these prominent epicanthal folds, and in their eyes they have these brush-filled spots as well. Their ears are more low set, they tend to have a shorter neck, and they have more hypermobile joints. And in terms of their organ systems, they have like cardiac septal defects, more likely to have duodenal atresia. In terms of the blood, they have an increased risk of getting acute lymphoblastic leukemia. Neurologically, they have intellectual disabilities and more prone to developing Alzheimer's, especially at an earlier age. So I think onset is around 35 to 40, but don't quote me on that. And in males, they're likely to be sterile, whereas females have a better chance of childbearing, and they are also more likely to be hypothyroid as well. Okay, got an SBA here, so I'll open up the polls and I'll read the question. So we got so what screening test is done routinely for Down syndrome at which dates? So I think Elisa mentioned which tests are done. I've added in some dates in there to make it a bit harder. I'll give it about 5 more seconds. Okay, I'm going to close the polls. So most of you answered B, which is correct. So fetal translucency is normally done between 11 to 14 weeks, and you can get the quadruple assessment at 14 to 20 weeks if you have a high suspicion of Down syndrome at that stage. Chorionic villus sampling is usually done at 11 to 14 weeks, but it's not a routine test. It's usually done if there's more of an increased suspicion of Down syndrome. And amniocentesis is done around 15 to 20 weeks, but it's not routine either. Yeah, and if you're too far along, then they can offer a 20-week screening scan as well, which looks for the physical defects itself. So it can pick out things like the kind of flat nasal bridge and any kind of limb defects and things like that too. And they tend to do that anyway, just looking at the heart and looking for heart defects and things like that around with every scan. Okay, next SVA. Just opening the polls. So what blood test results are associated with an increased risk of Down syndrome? Yeah, I'll give it about 5 more seconds. I think this is the last SVA. Okay, I'm going to stop the poll now. So most of you answered A, which is correct. So if there's an increased risk of Down syndrome, you'll typically find on the blood test that there's a high beta HCG and a low PAP-A. You'll also find when you're doing the quadruple test a low alpha fetoprotein and a low estradiol as well. And these are the 4 things that you do in your quadruple test as well. So I've just put in all the information onto one slide for you about this. So that the initial screening, the nuchal translucency, doesn't just look for trisomy 21. It also looks for trisomy 18, which is your Edwards, and trisomy 13, which is Pubertal's. And the diagnosis is with sonography, which mentioned as well, and it's that nuchal fetal nuchal translucency is done alongside your beta HCG and PEP. Your anomaly scan is between 18 to 20 weeks, and that, like I mentioned before, detects your malformations such as your flat facial defects, any microglossia, shortened femurs, any kind of lack of ossification in any nasal bones or shortened fingers. Looks at your heart and looks at your kidneys as well. Just going on about the quadruple test. So I mentioned the 4 different ones. So your alpha fetal protein is made by the baby itself. Your beta HCG is made by the placenta. Your estriol is the hormone also made by the placenta and the baby's liver. And your inhibin A is another hormone made by the placenta. And you're just checking all of these to detect if there's any abnormalities, because the cells of the placenta as well as the fetus are from the same kind of embryo. And then your amniocentesis and your chorionic villus sampling are both genetic tests, but there is a risk of miscarriage, which is why they're not done routinely and only if there's a very high suspicion. Okay, and in terms of management for Down syndrome, you'll look for any kind of organ malformations and treat those. So if the patient's hypothyroid, you give them thyroxine. If they've got any congenital heart defects, you'll monitor it. In some cases, you might need surgical intervention. And with any MSK issues, so if they're hypermobile joints, for example, you'd give them physiotherapy. They'll have regular medical checkups, just monitoring all their systems, especially as newborns and infants. And you'd also look for any kind of eye disease, such as cataracts or strabismus. And there's always the kind of social side of things that you think about as well, and the support for the patient in their own environment and the family as well. So I'm not going to go through all of these, but I put this table together as a revision for key features you need to know for each of these different syndromes. So the 3 trisomies here, so your Downs, Edwards and Pubertal's, and just how to differentiate them. I've also put in Klinefelter's and Turner syndrome, which affects sexual development. Some of the other ones that you might need to know are your Kruder-Schatz, Prader-Willi, Angelman's and DeGeorge syndromes, which commonly also come up in exams, and I put down the key features in there. So I'll let you guys look at this in your own time. Yeah, and then just trisomies that I've listed here, which are likely to cause miscarriages or newborn deaths. Trisomy 8, 16, 22 and trisomy 9 are usually the more fatal ones, or they're lost early in the pregnancy. Cool. So thank you guys. I think Anaya is presenting next, and I think she's the last one tonight. Well done guys for sticking through this. And if you have any questions, please do email or put it in the chat, and I'll happy to answer. And hope you enjoy my little animation there of the talking baby.
I'm sad that I can't see your questions.
Oh. Okay, I'll just be sad.
So I'm going to be doing a run through of elderly care. It's a bit of a mishmash of lots of different things for this week. So it's a bit disjointed, but it's just kind of a quick run through of some of the main topics that come up in elderly care. So we're going to start off with an SBA.
I'll start off.
Thank you. So you're listening to a podcast discussing the theories of aging on your way to work. They're discussing the theory that our resources are finite and the rate of aging of a species is determined by the amount of investment they put into self-maintenance. What's the name of this theory of aging? So wear and tear, adaptive evolutionary, non-adaptive evolutionary, disposable soma theory, or none of the above?
Give it about 5 more seconds. I think we've also lost quite a few people as well, so
Yeah.
okay, I'm going to stop the poll now.
Cool. So I can see most people have put A, which I can kind of see why you've put that, but the answer is actually D. So I'll give you a quick run through of my summaries of each of them. I'm sure there are much more coherent summaries out there. So wear and tear is kind of just the theory that your body is like a machine that just eventually wears out. So aging results from just kind of a gradual deterioration of the cells and tissues by just wear and tear, oxidative stress, exposure to radiation, and other just deteriorative processes. So that's probably the most simple of the theories. Then second, you've got adaptive evolutionary. That's the theory that aging is beneficial to the species as a whole because it results in less competition for resources, for example. Then the third is non-adaptive evolutionary, which is a theory that doesn't really have much backing behind it, but it's the theory that you have kind of these early expressed genes that affect most of the population, and they're the ones that kind of affect who kind of reproduces, and genes that are expressed after you've reproduced aren't going to be kind of taken into account in that process. So aging is due to a collection of these late acting genes that you don't pick up before reproduction. That doesn't have much backing to it, and it's not kind of probably one of the least thought about theories. And disposable soma theory is one that kind of, as in the question, says that we've got a finite set of resources and our lifespan depends on how much of our resources we invest in kind of growth and reproduction versus self-maintenance, so anti-aging repair in the picture here. And it kind of fits in with the fact that rabbits reproduce loads, don't invest much in their self-maintenance, and they have a short lifespan, whereas kind of larger mammals who don't reproduce as much invest a bit more in their self-maintenance, and they have a longer lifespan. These theories are kind of, I think it's probably not going to come up too much, but they're just worth knowing about. So next topic of the week is osteoporosis. So osteoporosis literally means porous bone. And it describes this reduction in bone density due to an imbalance in the bone remodeling process. And what it leads to is like this picture up on the right hand side. You have this bone with kind of these big gaps in it, kind of bigger holes than normal, so it's just more porous. And the picture on the right at the bottom just shows that your bone mass kind of peaks between 20s and 30s. And then as you get a bit older, particularly for women post-menopause and men post about 50, your bone mass just starts to decline. And the other patient group to think about is patients taking corticosteroids. They're really at risk of having osteoporosis. And the main problem with osteoporosis is that it leads to these pathological fractures, in particular of the spine, hip, and the wrist. And they're the main reason osteoporosis would be picked up is because of these fractures. So SBA 2, what is the correct definition of the Z score? And this score refers to a DEXA scan, which hopefully you've heard of, but it's an X-ray imaging technique that's used to work out someone's bone density.
I'll give it 5 more seconds.
Yeah, sounds good.
Okay. Stop the poll.
Cool. So most of you have put A, which is the correct answer. The second one, so the difference between your measurement and that of a young healthy adult, is what we call the T-score. So next, SBA. What T-score is needed to diagnose osteoporosis? Osteoporosis? I said that really weirdly. Osteoporosis. So less than -1, greater than or equal to -1, less than or equal to -2.5, greater than or equal to -2.5, or less than or equal to 3. So open the poll.
Sorry, just didn't click for some reason.
No worries. Cool. I think people are quite speedy on this one already, so we will move on. So yeah, correct. The answer is C. So osteopenia is kind of the one stage before diagnosing osteoporosis. So you've got slightly less density to your bones, and then osteoporosis is where you're really at risk of those pathological fractures. But you just kind of have to memorize, but -2.5 is the thing, which seems like you already know, so just keep that in mind for exams. So in terms of managing osteoporosis, you're going to check their calcium and vitamin D and make sure you give them supplements, and supplements if they need it to replace it. And then first line management is bisphosphonates, and they inhibit osteoclasts. And osteoclasts, I remember, osteoclast crash bone, osteoblast spill bone. So osteoclasts are involved in kind of breaking down bone. And some names just for you to remember: alendronic acid and risedronate. And then some other options: you can use raloxifene or denosumab, which inhibit rank L. And rank L is involved in the maturation of osteoclasts. So that's how that works. I wouldn't worry too much about how they work, but just bear in mind bisphosphonates, the first line, is probably the most important thing to know. And then we're going to go on to causes of falls in the elderly. So falls are really, really common in the elderly. Loads of people in hospital come in due to a fall. And my way of remembering the different causes of falls is to use the mnemonic DAME. And it also helps you to remember that falls are actually a lot more common in women than in men. So the D of the mnemonic stands for drugs and alcohol. So first thing you should do if someone has a fall is look at their drug chart, check if they're on any antihypertensives, if they're on any beta blockers, any diuretics. If people are on loads of different drugs, so polypharmacy, that massively increases their risk of falls. Check their Parkinson's disease medications are optimized, and check that they're not hypoglycemic as well. And then A stands for age-related causes. So if they've got kind of visual problems, which is more common in elderly, MSK causes, so are they just quite weak? And do they have poor reflexes, so are they just less able to steady themselves if they trip? M is for medical, so things particularly like stroke, malnourishment, epilepsy, cardiac arrhythmias, infections, in particular UTIs in elderly. It's really important to do a urine dip if someone has a fall, because that could be the cause. And BPPV, which is this positional vertigo that you may or may not have heard of. And E is environmental, so did they just trip over something or slip? And was the lighting poor that led them to tripping over something? So you're working in the doctor's office of your senior health ward. When you hear the alarm bell sound, you run over to B-Bay and find Mrs. Higgins on the floor by her bedside. The nursing staff say no one witnessed her fall. So what are you going to do next? What would be your way of approaching this patient? So I'm not sure if I can see the chat, so if Ash, if you can read out people type.
Yeah, I can. And there is a question just to go through SBA 2 again as well, just when you're done with this.
Yeah, Okay, we'll do this one and then we'll maybe go back at the end. Can't remember what SBA 2 was now. But yeah, we'll go back at the end. So
there's nothing. If people just want to write whatever they think in the chat, it would be great.
Yeah, can be very basic things like just ideas of investigations you might want to do, or just how you'd approach them in general. Like what would be the first?
Sorry, got check for osteoporosis.
Yeah, definitely that's something you would want to think about a bit later down the line for sure. Maybe give me 2 more things and then I'll move on. Just think about it. If you walked over to this patient on the floor, what would be the first thing you'd say or first thing you'd ask the nurses to do?
Ask how they fell.
Yeah, perfect. So you take a good history, wouldn't you, and ask what happened, and ask if they're in pain as well. All right, it's quite late, so unless people are typing, I'm going to move on.
Yeah, no one's typing.
Okay, perfect. I'll move on and go through. So yeah, like you said, first thing, go through a bit of a history. So ask if they're in any pain and ask how they're feeling now. Ask a bit about what happened. So particularly split it up into what happened before, during and after. And then ask them, has it happened before? Like, are they a frequent faller? And then do a bit of an examination. So on the wards, the first thing I do if someone has a fall is check their vital signs, see if they've got low blood pressure, see if their heart rate's particularly low or fast. Then I do a full examination really for a fall. So I do a cardiovascular examination, respiratory examination, a neuro exam, including checking their vision and checking their cognition. So doing a cognitive screen, just see if they're a bit delirious perhaps from an infection. And then I'd also do a quick GI exam. Mainly that one is for seeing if they've got any pain that might suggest they've got a UTI, or they could be dehydrated as well as another thing you might pick up. And then some possible investigations depending on what you think might be the cause. But some common ones you'd want to do are a lying standing blood pressure. That's pretty routine in everyone who's had a fall, as with an ECG. You'd want to get some bloods, looking at if they're dehydrated, maybe they've got an infection. Definitely want to check their glucose, see if they're hypoglycemic. Do a urine dip, because like I said, urine infections are really common. If they're in pain anywhere, you want to get an X-ray. You might want to do a CT head if you're suspecting a stroke, or if they've hit their head, you need to just check that they haven't had a bleed. And echoes and 24-hour ECG tapes are really common if you're suspecting an arrhythmia or some kind of cardiac cause of their fall. So SBA 4. Mrs. Smith, an 84-year-old lady, was walking in the park when she tripped over a small dog. On X-ray, this is seen. What is the correct name and description of the fracture? So is it a Smith's fracture with distal radius fracture with dorsal displacement, a Smith's fracture which is distal radius fracture with volar displacement, a Colles fracture, distal radius fracture with dorsal displacement, or Colles fracture, distal radius fracture with volar displacement?
We'll give it 5 more seconds. I think most people are answering so far.
Cool.
I'm going to start the poll now.
Yes, sounds good. So we've got a bit of a split. The answer is C. I've always found this a bit confusing in terms of whether it's kind of dorsal or volar displacement. And you've just got to remember that displacement of a fracture, you always look at the distal part of the fracture and which way that's moved. So in this diagram, the distal part of the hand above the fracture is moved dorsally. So dorsal is the back of the hand, volar is towards the palm, and this end bit of the fracture is moved dorsally. So that's why it's a Colles fracture. And Smith's fracture is the opposite. So Smith's fracture, they say, looks like a garden spade, and it's when it's displaced ventrally. And Colles fractures, they compare to a dinner fork, and if you see patients with it, it's more obvious in person really than, or like if you see this picture here, that's what it looks like. And the mechanism of injury of both is slightly different in that Colles fractures, you fall with the hand in its extension, whereas Smith's fracture, usually they've fallen with their hand in flexion. So SBA5, a bit of anatomy. So which carpal bone is the arrow pointing to? Is it your lunate, scaphoid, trapezoid, hamate, or trapezium?
Well, I saw that image when I was going through the sides, and it kind of creeped me out. There were no proper fingers on there.
No, really? Just that it's cut there. I think I see a lot of funny looking hands on plastics at the moment, so I'm not, didn't even occur to me. All right, I think most people have answered now. I'm going to stop the poll. So, answer is your trapezium. So my mnemonic for remembering this is straight line to pinky, here comes the thumb. So straight line to pinky, here comes the thumb, just because it helps you remember which direction they're going in. There are other ones, but that's my favorite one. And I also, because there are 3 T's, which I always found a bit mean. My silly way of remembering it is that triquetrium sounds quite different. It's like quet, and it makes me think quite different. So that's in the other row. And then you've got your trapezoid and trapezium. And trapezoid kind of sounds like trapped, if you say it quickly and wrong. So I think of trapezoid as like trapezoid between 2 bones. So that's the one in the middle, and then your trapezium's the other side. But that's my silly way of remembering it, but I'm sure there are lots of different ways. But this is quite common anatomy that you need to just memorize, because it comes up really frequently. So we're going to move on now to a bit about malnutrition. So there are many reasons why malnutrition is really common in the elderly. So some of the factors are that you get this kind of age-related reduction in appetite. Their basal metabolic rate drops quite a lot, and they're just not as hungry. And also their sense of taste and smell can change, which will make them kind of have less of an appetite. Also, dementia plays a big part, so that can just mean that they'll forget to eat or forget to go shopping. Also, illnesses and just being on lots of different medications, that can affect your metabolism and appetite in lots of different ways. Loneliness is a really big thing to think about in the elderly. They can find eating alone just isn't as enjoyable, or they can struggle to get access to food shops without help. And also just physically, they might be just struggling to eat. So they might struggle to swallow and chew, struggle to feed themselves, which can be another cause. And the problems caused by malnutrition are pretty vast. So some of the key ones just to pick out are it increases your risk of falls, either through electrolyte abnormalities or through just muscle weakness as well. Can increase your risk of infections because it weakens your immune system. In general, malnutrition causes lots of hospital admissions, and in particular, if your kind of respiratory muscles are a bit weaker, you're more susceptible to pneumonias, and pneumonia is really common in elderly. And yeah, overall just increases the risk of death by a lot. So it's something to really take seriously. So SBA 6. Which of these is a score used to evaluate malnutrition? So is it MAST, MUSC, MUST, MUD, or MMSE?
Okay, I'll give it 5 more seconds in case anyone wants to do anything else. Okay, stopping the poll now.
Cool. The answer is the MUST score, which stands for Malnutrition Universal Screening Tool. I think I made up most of them, apart from MMSE, which we'll go through a bit later. MUST is, a score that just helps in hospital. It's a really quick way of assessing if someone's at risk of malnutrition. So it involves looking at their BMI, giving them, so that's one part of the score, then giving them a score for whether they've recently lost a lot of weight or not. And then the third one is whether they've been acutely ill or not. And you kind of add up those scores together, and if they've got a score of 2 or more, they're high risk, and then you need to go on thinking about referring them perhaps to the dietitians or kind of how you're going to help them. Whenever you refer to dietitians as well, they ask for the MUST score. So next, SBA. What is the name of this cognitive assessment? So is it a 4AT, MMSE, MOCA, AMTS, or a PHQ-7?
Cool, I'm going to stop the poll now.
Perfect. Yeah, it looks like you guys have seen these before. They're really common on the wards, and it's such a common, when you start your placements, it's a classic med student kind of job that you'll get asked to go and do these all the time. So I'm sure you'll be very familiar with them. But MOCA, it helps kind of detect mild cognitive impairment and Alzheimer's dementia as well. So you just ask them to do all these different kind of basic tasks, and it's actually quite surprising. I found I did geriatrics as my first placement, and it's surprising actually how many people you can have a really good conversation with and think aren't particularly struggling, and then when you go to do an actual cognitive assessment, they find it really hard. So these assessments are really useful just to properly assess someone, because it can be masked really well socially. And so that was my last SBA. I'm just going to quickly run through what all these different scores look like, because there are quite a few different cognitive assessments. And I think for now it's not really important that you know them really well, but I think it's just something that I just want you to be aware of them all. So the 4AT is this rapid test, really quickly done on ward rounds, and it's mainly to assess for delirium. So if they score 4 or more, it means delirium plus or minus cognitive impairment is really likely, and you can do it really quickly. It's checking their alertness, asking them age, date, date of birth, place, current year, and then asking them to name the months of the year in backwards order, and then just saying whether or not it's acute or fluctuating. AMTS gives you a score out of 10, and you get a point for each question you answer correctly. So these are questions that, as you get through med school, you'll probably start memorizing, because it's quite a quick screen to do as well. Your MMSE is another test of cognitive function. This is what it looks like, and it includes kind of tests of orientation, attention, memory, language and visual spatial skills. They take a bit longer to do, and it involves things like asking them to follow instructions. So there's a bit in it where it's like, take this bit of paper in your right hand, fold it in half, and then put it on the floor. And it's kind of a bit more comprehensive than the other tests. And then one that's really important to mention as well is your PHQ-2 and 9. And these are screens for depression, and depression is really common in the elderly and really commonly missed. So your PHQ-2 is just what I've shown here. It's really quick, really straightforward. And then if they score highly on the PHQ-2, then you go on to do the PHQ-9, which is a bit more of a longer depression screen, which you absolutely don't need to memorize, but just be aware of. And I think that is everything. So if you guys don't mind scanning the QR code and doing the feedback. There was a question, wasn't there, though, to go back to, was it SBA 2?
Question 2, yeah.
2. Let me scroll back. SBA 2. Yeah, so the Z score, these questions were to do with DEXA scans, which are these X-ray scans that work out your bone density. And there's 2 different scores. So the first is your Z score, and that takes someone of kind of the same background as you and evaluates you against someone of the similar age, sex, weight, and ethnic origin. So that's the first kind of score they'll give you. And the second one is the T score, which just measures the difference between you and, I think it's that of a 30-year-old adult, I think of the same sex, but I'm not sure, is the T score. So they're the only 2 scores you really need to know. And I'd say all you need to know about them just is the definition. And then this question here is, I think, all I've ever been asked. I don't know if the rest of you have been asked other things, but basically these 2 questions are the only questions I remember being asked about osteoporosis, really. Does that answer your question?
Yeah, we got a yes and a thank you.
Okay, perfect. Let me go back to the QR code at the end. Are there any other questions about this module in general, or about anything?
Yeah, please feel free to like unmute yourself and ask questions. I thought the yawning Simba was quite suitable for the end of the session. And
Yeah,
well done,
thank you so much for sticking around so late today.